All right, that birding means it is time to go ahead and get started. So, welcome. I see some of you are joining on Facebook and YouTube as well. Hello. Thank you so much for joining. And as you can see, we're going to be doing, in my opinion, a really fun webinar today. It's just going to be a short one. It's going to be around 30 minutes. So, I'm not going to eat up too much of your day, I promise. But we're going to cover some interesting stuff. As you can see, we're going to really dive into fetal heart rate monitoring. Now, for any of you who find this to be a hard topic, tell me in the chat or on YouTube or on Facebook. Tell me if you are one of those people who says, man, this is tricky stuff. And I'll admit to you guys, that was me. That was me too. When I was in nursing school, I was not a fan of fetal heart rate monitoring. It wasn't described very well in my schooling. I really didn't feel very prepared when I went into my NCLEX. I did end up passing, but luckily I didn't get many of these questions. But really, today our focus is to get you through the basics of what you need to know to be able to monitor a fetal heart rate strip. Now, just so you guys know, you do not need to be a maternity expert to pass the NCLEX. You do not need to be a fetal heart rate monitor expert, I promise you. But you do need to at least know the basics, and that's what we're going to cover today, because let me tell you, maternity, labor, and delivery, it's going to come up quite a bit on the NCLEX. So I want to make sure you guys feel very confident with this. Yeah, I'm seeing in YouTube and Facebook, a bunch of people are like, yeah, I'm not a fan of this. Well, hopefully I can change your mind by the end of today's session. Now, a couple quick announcements. First of all, you got to know who I am, of course. My name is Elizabeth Diger. I'm actually a women's health nurse practitioner. I spent about a decade working in OBGYN, but prior to that, I was a critical care nurse. I worked in the ICUs and emergency departments. And of course, now I'm working with Archer. I've been here for going on 3 years now. I do a lot of lectures for Archer. And of course, I'm very excited to give you this lecture today. Now, a couple quick things. For those of you on Zoom, you've already figured this out, it looks like. I want you to put your answers in the chat. Throughout today's lecture, and those of you who know me know I do this a lot, I'm going to be asking you lots of questions. So when you answer those, I want you to put those right in the chat. Now, on the other hand, if you have a question, if you're like, hey, Elizabeth, this doesn't make sense, that's when I want you to use the Q&A. And I'll be keeping an eye on the Q&A, and I'll really try to answer those questions as we go. So that being said, let's go ahead and get started. And good morning. I see a couple of you popping on saying good morning. Welcome. Okay. So, and one thing I should mention, guys, is we are not going to be using Slido today. So don't worry about a Slido code. I want you, if you're on YouTube, on Facebook, I want you to just answer right on those platforms. And again, if you're in the Zoom webinar, go ahead and use that chat. So no Slido today. But first of all, before we dive into the big stuff, we have to cover some terminology, right? You got to know what the basic terms are before you can interpret fetal heart rate monitoring. And so basically, let's start with variability. Let me get my little drawing tool here. I'm going to need that. So variability is the fluctuation in the heart rate. It's how high and low it varies from the baseline. Now, tell me, guys, is this a good variability? That line I drew right there, that flat line, is that what we want to see? Tell me in the chat. Tell me on Facebook. Tell me on YouTube. What are you guys thinking? Ooh, I'm getting some mixed answers. Yes, you guys who are saying no, you are correct. We don't want to see a flat line for variability. We want to see movement in the heart rate. Think about yourself as you're sitting here watching this lecture. your heart rate isn't just one consistent number, it fluctuates based on what you're doing. And we want to see the same in the fetus. Next term is an acceleration. And accelerations and decelerations are just like what they sound like. Accelerations are a speeding up of the heart rate. That's when the heart rate goes up. That's usually a good thing, right? On the other hand, decelerations are a slowing down of the heart rate. And usually that's not good. But as you're going to see today, we do have a few different types of decelerations, and some are more concerning than others. And again, we're going to go over those more in depth in a little bit. But there are two really big terms that I want you to really understand, especially this one right here with all the arrows I'm pointing at it. So absolutely, when we're doing fetal heart rate monitoring, we want it to be reassuring. That means, hey, baby looks healthy, everything's okay right now, we can just keep monitoring. On the other hand, if we have a non-reassuring fetal heart rate, that's when we as the nurse have to act. And just so you guys know, there are 5 non-reassuring signs, and we're going to get to those in a little bit. But if you only take away one thing from today's lecture, I want you to know what are the 5 signs of a non-reassuring fetal heart rate, and I want you to know what to do with it, because that's what they're going to ask you on the NCLEX. Now, like I said, variability. Remember, a very important term. This is how much that heart rate varies from the baseline. And again, guys, we don't want a straight line. We want variability. So let's look at the different types of variability. This would be absent variability. So remember earlier, I drew that straight line. Rarely is a fetal heart rate just going to look like a straight line. Usually it's at least going to be a little bit wavy. But if you see this on the heart rate monitor, this would not be good. This is what we call absent or minimal variability. This would be one of the 5 non-reassuring fetal heart rate sounds. And let's look at this. This fetal heart rate, it's about 120 on average. And it doesn't really vary from that very much. So if you have a fetal heart rate, it's mostly a flat line. It's maybe varying 5 beats per minute or less. This is something you need to follow up on. So make sure you're aware of that. Now, on the opposite end of things, we can also have marked variability. And this is when the baby's heart rate is just all over the place, as you can see. It looks like in this one, maybe that baseline is around 130, but look at how much it's varying. It's going all the way up to 150. It's going down below 120. So it's varying by more than 25 beats per minute. And this could be good or bad. This is a little bit trickier to interpret. It can be ominous. It can be something concerning, or sometimes it's not a big deal. It really depends on what's going on. So let me ask you another question. I'm going to keep peppering these questions at you here. So what do you guys think? If you see this on the monitor, but the baby's mom is actively pushing, she's about to deliver, do you think it would be concerning to see marked variability when mom is actively pushing? Would it be concerning? What do you guys think? Yeah, not as much. I'm seeing a lot of very good answers in Facebook, YouTube, the chat. You guys are on the right track. Absolutely. If mom is actively pushing, if she's about to deliver, I would maybe expect to see some marked variability. That's putting a lot of stress on the baby, and we would expect that heart rate to vary a bit. Now, how about this? What if mom is taking a nap on the couch and then we see this marked variability? Would that be concerning? So mom's just sleeping. You guys got it. Yeah, you guys are thinking along the right track. Exactly. If mom is just resting and we see a heart rate varying this much, that really tells me that fetus is probably in distress. And again, I need to do something about that. And we'll talk about those interventions in just a little bit. So again, this can be a little bit more challenging than that absent variability where, if you see that flat line, you pretty much always know something wrong is happening. With marked variability, you got to use a little bit more of that critical thinking to decide what to do. On the other hand, this is what we want. This is what we usually see, that moderate variability. So with this one, that baby's heart rate is about 120, 130, and it has some slight variation, not too much, not too little. It's just right. It's just where we want it. And it varies between 5 and 25 beats per minute. So it's varying a bit, but not too much. And this is expected. Again, it really indicates that we have a healthy baby here. And this is very reassuring when we see it. Now, of course, accelerations, we always want to be seeing these accelerations. And again, this is just what it sounds like. That baby's heart rate is increasing, it's accelerating. And they're going to look something like this. So on the bottom here, the bottom reading is going to show the contractions. And it looks like this client, this mom, has had 3 contractions on the strip. 1, 2, 3. And remember, we always match the fetal heart rate to the maternal uterine contractions. We put those right side by side, like you see on this slide, and that way we can compare. And basically, the top reading here, as you can see, that's going to show the fetal heart rate. That's showing the response to those contractions. And again, that's why we put those readings right next to each other. We want to see, okay, if a contraction happens, what does the fetus's heart rate do in response to that? And in this case, for every contraction, the heart rate is increasing. It's jumping up. And that's what an acceleration is. And it's always a good thing when we see an acceleration. In fact, and we might have time to get to this at the end, I'm just going to see how we do with our time, but this is what we look at or what we look for when we're doing a non-stress test. With non-stress tests, remember, we do those for 20 minutes and we want to see, okay, is that fetus having an acceleration in response to the contraction? And it basically tells us whether or not that fetus is tolerating the contraction. Because I want you to remember something very crucial here. Every time that uterus contracts, it's squeezing the fetus. It's squeezing the placenta and umbilical cord. And what do you guys think? When that contraction is squeezing the placenta and umbilical cord, is that putting any stress on the fetus? What do you guys think? Tell me wherever you are what you guys think. Absolutely it does. Yeah, it's stressing that baby out. And what do we want that baby's heart rate to do in response to that stressor? We want it to go up. That tells us that the fetus is rising to that occasion. It's meeting that stressor. And of note, guys, something else I want to ask you. Would this be a good acceleration here? This little one I'm drawing right here. Would that count as a good acceleration? Good. I'm seeing a lot of no's. Excellent. Make sure, guys, in order for it to count as a high quality good acceleration, it needs to follow the 15 by 15 rule. It needs to go above the baseline by at least 15 beats per minute, and it needs to last for at least 15 seconds. Excellent. Okay, but this is when the opposite happens. Next, we have our decelerations, and we characterize these in a few different ways. And really, it depends on the timing of that deceleration with the contraction. And it also depends on how that deceleration appears. And as you can see, there are 3 types. And I bet if any of you guys earlier were like, hey, Elizabeth, I don't really like these fetal heart rate questions, I bet it's the decelerations that tripped you up the most. I remember struggling with these a lot. But again, we're going to really break these down over. Yeah, these are the hard ones. I totally agree. We'll make them hopefully a little bit easier for you. Okay, so first of all, we have our early decelerations, and these are going to occur in time with contractions. So as you can see here, mom has the contractions. It looks like she had 3 contractions in this monitoring period, and she has decelerations that mirror that contraction. So with early decelerations, the deceleration happens at the same time as the contraction. And as you can see, they start and they stop at the exact same time. And with early decelerations, they're going to make a U shape, a nice U shape, because the heart rate's going to drop slowly and it's going to rise slowly. So that's how you're going to identify them. Now, I have to ask again, I'm going to keep asking my questions. What do you guys think? Are early decelerations something to be pretty worried about, or can we just keep monitoring these? Are they worrisome or not? Good. Ooh, I'm very impressed. Yeah. Yeah, believe it or not, guys, these are considered neutral. So they're not good necessarily. They're not necessarily like, oh, yes, I'm seeing early decelerations. It's not necessarily a good thing, but it's also not necessarily a bad thing. It's just a neutral finding that you can continue to keep monitoring. Now, the reason I don't have to worry so much about this is I know what causes it. It's head compression. So remember, early decelerations are caused by head and neck compression. Exactly. Especially when the mother is actively pushing. When there's active labor, think about what's happening. That baby is going through that birth canal. The contractions are compressing the baby's head and neck, and that's going to stimulate cranial nerve 10. We also call that the vagus nerve. Now, what happens to the heart rate normally when you stimulate cranial nerve 10? What do we expect to happen? Exactly. We actually expect bradycardia. Exactly. When you stimulate that cranial nerve 10, the heart rate is going to decrease. And that's just an expected finding. It's not due to a lack of oxygenation. It's just a normal response. That's why we don't have to worry too much about it. And basically, as long as that heart rate comes back into normal range after the contraction, we're okay. We can just keep an eye on these things. Now, next up, we have our variable decelerations, and this is a totally different story. Now, these usually also happen at the same time as contractions, but they can also happen out of time with contractions, and I'll tell you a little bit more about that in a minute. But like I said, they're usually going to happen at the same time as the contractions, just like we saw with early decelerations. But what's the difference here? What makes these different than those early decelerations? What are you seeing? Good, Paula. The shape is different. Very, very good recognition, guys. Remember, with these early decelerations, they make a U shape. The heart rate drops slowly, it rises slowly. And that tends to be a lot less concerning than this V shape. Exactly, guys. Remember, V for variable, V for variable. And really, the big difference is that heart rate is dropping much faster right after that contraction happens. That heart rate plummets, And as soon as that contraction ends, that heart rate spikes right back up to the baseline. So it makes that V for variable, just like you guys are saying. Now, what causes variable decelerations? What physiologically is happening here? Good. You guys are remembering. I love seeing this. We are going to see this with cord compression. And can we just monitor that? Can we see a variable deceleration and be like, oh, they're fine, I'm going to walk away? No, this is one of those situations where something serious could be going on and action is absolutely needed. And the reason for that is you really have to think about what's going on when the cord is compressed. Remember, the placenta is attached to the mom, it's attached to the mom's uterus. And it's bringing blood, it's bringing oxygen and nutrients to the baby through that umbilical cord. And you got to think of that umbilical cord as a lifeline. That's how we're getting oxygen to the baby. And basically, if that cord is compressed, if I cut off that blood and oxygen supply, that baby's in big trouble. That's why that heart rate is dropping so fast. Now, why would there be cord compression? Well, very commonly, this occurs if there's a condition called oligohydramnios. It's quite the mouthful. Does anyone know what is oligohydramnios? What am I saying there? Good. Low fluid levels, a lack of amniotic fluid. Exactly. And if there's a lack of amniotic fluid, that increases the pressure, that increases the squeeze when there's a contraction. So this can decrease the blood delivered to the fetus, because if there's not that amniotic fluid to cushion that baby and the cord and the placenta, every time there's a contraction, it's going to squeeze that cord and it potentially is going to cut off the blood supply. And that's very concerning, of course. That can lead to fetal hypoxia, then fetal acidosis. And how do we manage this? Well, like some of you guys said, we might try to reposition, see if that helps a little bit. We could also do something called an amnio infusion, where we actually do a saline infusion into the uterus, into that amniotic sac, to basically replace the fluid they lost. And that adds more cushion around the baby, so those contractions don't compress the cord. And of course, in really severe cases, exactly, Karen, we might do an emergency C-section, especially if we see what we're seeing here. These are deep V's. This baby, I think, is in very serious distress, especially, what do you guys think of the variability right there? Is that good variability in between those two V's that you're seeing? No, that would be that absent or minimal variability. And I would be pretty concerned by that. This is a baby. I would want to alert the provider right away, and probably they're going to end up having an emergency section. Now, I do want to note briefly that sometimes you can see variable decelerations in between contractions. So what do you guys think? If there's a variable deceleration in between a contraction, that certainly can be a lot more serious. Can anyone think what would cause the cord's blood supply to be cut off in between contractions? This is a hard question. What do you guys think? Cord prolapse. Very good. You guys made that look easy. Absolutely. If that umbilical cord slips into the vaginal canal and that baby's head, as it's delivered, compresses that cord, you're going to start seeing variable decelerations. And yeah, you got to notify that provider right away. Also, you got to lift that baby's head off the cord. What about, does anyone know what a nuchal cord is? Does anyone know what that means? What's a nuchal cord? Yeah, It's a cord that's wrapped around the baby's neck. So that, of course, would be another emergency. We'd probably want to consider a stat C-section in that case. Good thinking, guys. You guys are doing great. All right. Last of all, finally, we have our late decelerations. And we call these late because they happen late in the contraction. Usually they happen after the peak of the contraction. Now, again, you know what I have to ask? Are we worried about these? Are we worried about these? So you can see there's a contraction. Later, we see the deceleration. Contraction. Later, we see the deceleration. Absolutely. We are worried about these because what is happening here? What is causing this? What is causing these? Placental insufficiency. Absolutely, guys. And you can see they do make a U shape. There's a steady fall, steady rise in the heart rate, but it's a delayed deceleration when we compare it to the contractions. And yeah, you guys are right. Basically, the placenta isn't getting enough blood flow, which means that baby isn't getting enough blood flow. And what is a common thing? Tell me, guys, what pain control do most women get when they're having a vaginal delivery? What's that favorite pain control? Yeah, they love the epidurals. I did too, I'll admit. And what can epidurals do to your blood pressure? Hypotension. So really the number one cause, one of the number one reasons we're going to see this is if the mother gets an epidural and it causes maternal hypotension. So you really got to watch those moms when they have an epidural. But there are other things that can cause this. Placental abruption. If they're bleeding behind the placenta, not enough blood is getting to baby. Some other more benign sounding things, maternal dehydration or severe maternal anemia. These are all things that can lead to placental insufficiency. And of course, first of all, we're always going to try to treat that underlying issue. But if that doesn't work, we're going to deliver via C-section because these babies are not doing well in this case. So if you guys do get any, especially decelerations on your NCLEX, I want you to use that note page that they give you. And I want you to write VEAL and CHOP right next to each other, because that's going to remind you of what these are caused by. Remember, V for variable is caused by C for cord compression. This is an emergency. E for early deceleration is caused by head compression. What do we do when we see that? What do we do? Yep, exactly, man. We're just going to monitor, probably just going to monitor. Accelerations, remember, are always okay. And late decelerations are caused by placental insufficiency. So we would want to act for that as well. But this is the big takeaway I want you guys to have. I want you to know what is reassuring and what are the 5 signs of a non-reassuring fetal heart rate. So a fetal heart rate, of course, is reassuring if it's in normal range. We want that heart rate to be between 110 and 160. Remember, we want that moderate variability. We don't want a flat line. And we want accelerations. Those are always good to see. But there are 5 non-reassuring signs. Make sure you have these memorized. Fetal tachycardia over 160, fetal bradycardia under 110, decreased variability, variable decelerations, and late decelerations. If you see any of these 5, make sure you act fast. And remind me, guys, what do we do if we see a non-reassuring fetal heart rate? What mnemonic are we going to use? What do we do? Yeah. And again, if you get one of these questions on the NCLEX, I want you to write this down on your note page. We're going to do lion pit. Exactly. So what do you guys think we do first? Let's say let's say that we have someone who's being induced. They're like 41 weeks pregnant. We started them on some oxytocin to induce them. And all of a sudden we see variable decelerations. What do we do first? Yeah, you guys are not easily tricked. Absolutely. You guys are getting it. We're always going to stop the oxytocin first. We're always going to stop that Pitocin because remember, oxytocin increases the strength and frequency of the contractions. And remember, that stresses the baby out. So we got to stop the stressor. We've got to stop the oxytocin. Next, we're going to lay the mother on her left side. That's going to take that big uterus off of what vessel? What vessel returns blood back to the heart from the lower half of the body? I know you guys know this. Yeah, that IVC, the inferior vena cava. Very good. So if we turn her on her left side, that's going to take the pressure off of that inferior vena cava. And that means more blood, more oxygen can go to baby because it's being oxygenated in the heart. More blood gets to the maternal heart, more blood and oxygen gets to the baby. It's going to help that fetus in distress. That's also why we're going to increase IV fluids. If we increase the blood volume, again, more blood, more oxygen are going to that fetus. Now, we might give oxygen, but let me ask you guys a question. If the mother is already saturating at 99%, is it really going to be helpful to give oxygen in that situation? Yeah, not really. So you got to use your critical thinking here. If the mother is already saturating close to 100%, giving oxygen probably not very helpful. But if she's desaturating, that's when we're going to give that oxygen. And then finally, we're just going to notify that provider so they can determine next steps. Okay. And we made it through fetal heart rate monitoring. I know that was quick. Let's do one practice question and then we'll wrap up. I want to test your knowledge really quick. So let's try this. And I want you to answer in the chat or YouTube or Facebook, wherever you are. So this question says, the nurse is caring for a pregnant client who is, it looks like there's a typo there, who is experiencing late decelerations. Which of the following actions should the nurse take? So what do we do here? And it is a select all that apply. It doesn't say that, but this is select all that apply. What do you guys think? Ooh, I'm seeing some very good answers. Nice work. All right, let's go through it together and then we'll wrap up. So B, C, and D are our correct answers. Remember, we're going to lay that mother on her left side. Only if she's desaturating, we're going to give mother oxygen and we're going to discontinue the oxytocin. We are not going to initiate mag sulfate. Remember, mag sulfate we might use for preterm delivery. We might use if she has preeclampsia or something like that. And we're not going to do an amnio infusion. When would we do an amnio infusion? When would we instill that saline? Yes. If we see variable decelerations, that's when we might consider that treatment option. Very good. Yeah, in this question, I would assume her oxygen level is low. They didn't give you all the information I would have preferred. I agree. But I would just assume, yeah, probably that oxygen level is low in this case. So excellent job. And we made it through fetal heart rate monitoring. So thank you so much for joining me. I have to ask really quick, tell me in the chat, tell me in Facebook, how are you guys feeling about this topic now? Hopefully a little bit better. I'm seeing some greats. Oh, I love seeing that. I'm seeing some betters. Excellent. And remember, guys, if you have an account with Archer, hey, don't worry. You can rewatch that on demand video on fetal heart rate monitoring as many times as you want. It's also going to be in the maternity lecture as well. So feel free to rewatch this material. It's tricky the first couple times you learn it. All right. I want to wish you guys a great rest of your week. Again, thank you so much for joining. You were a wonderful audience. And I hope you have a wonderful weekend as well. Take care, everyone. Have a good one.